Hi, my name is Kirk, and today I'd like to share with you an evidence-based research article. My article was by Johnson and Tabasum in 2003, and it was published in the Journal of Physical Therapy. The article is entitled, An Investigation into the Analgesic Effects of Interferential Current and Transcutaneous Electrical Nerve Stimulation on Experimentally Induced Ischemic Pain in Otherwise Pain-Free Volunteers. The purpose of this study was twofold. Research conducted by Johnson and Tabasum in 2003 was aimed at investigating the pain-relieving properties of interferential current, IFC, and compare these effects to transcutaneous electrical nerve stimulation, TENS, and a placebo sham electrical stimulation. Through this investigation and comparison, this research aims to provide reliable and replicable data regarding the effectiveness of IFC as compared to TENS in otherwise healthy participants that may be drawn upon to guide clinical treatment approaches and methods in the future. Methodology, sample size, and study design. The inclusion criteria for this study included no previous TENS-like device experience, so participants could not have experienced TENS-like devices including IFC before. Additionally, participants must not report any painful medical condition within the previous 2 weeks. Exclusion criteria included contraindications to the use of TENS and IFC, as well as the likelihood of taking medication during the trial period. Expression of firm beliefs about the effectiveness of TENS or IFC, meaning that they have experienced it before and they believe that it does work or does not work, or if they strongly feel that it is invalid, and signs of previous trauma to the non-dominant arm, and these were all teased out through interview processes. Sample size was 30 university student volunteers, 18 male and 12 female. The study design is a level 2 case control study, taking advantage of a single blind sham controlled study. This test was administered by causing ischemic pain through the submaximal effort tourniquet test, the SET. Maximum grip force was established with a dynamometer, and that will come up again in a second. A cuff was applied to the 5 centimeters below the elbow crease. Participant's arm placed in extended overhead position while the cuff was inflated to 200 milligrams of mercury at an inflation rate of 40 milligrams of mercury per second. The participant's arm was returned to a horizontal position and supported by a cushioned seat, and then completion of 20 hand grip exercises at 75% of maximal grip force that was determined previously was conducted for 1 minute. The cuff was deflated, and over a 2-minute period that occurred. Experimentally induced ischemic pain is described as a dull, aching sensation and is the result, in this case, of accumulation of analgesic metabolites including histamine, bradykinin, serotonin, and adenosine. 3 randomized groups were allocated: 10 participants to the IFC group, 10 participants to the TENS group, and 10 participants to the sham electrotherapy group. Interferential current was applied from a modulated frequency of 100 hertz generated by a 4 kilohertz sinusoidal waves. It was established at a strong but comfortable sensation per the patient's description. Quadrupole electrodes were placed at an anterior and posterior forearm surrounding the cuff, so the cuff is placed in the middle of the forearm, 5 centimeters below the elbow crease. 2 pads were placed here and 2 were placed here. And an average amplitude of 19.2 milliamps with a standard deviation of 10 milliamps up or down was given to the IFC group. The TENS group was set up at 200 microsecond biphasic pulse currents at a frequency of 100 pulses per second in a continuous pulse pattern. This was again established as a strong but comfortable sensation as described by the participant, and the electrodes were arranged in an identical fashion to the IFC group. 2 electrodes below the cuff and 2 electrodes above the cuff. And an average amplitude for the TENS group was 11.3 milliamps, with a standard deviation of 2.7 milliamps. The sham electrotherapy had an identical electrode placement, the same as the cuff placement, and there was no current being conducted through the electrodes. Outcome measures that were investigated in this study included the self-report McGill Pain Questionnaire and the self-report Visual Analog Scale. On the McGill Pain Questionnaire, 15 NPQ descriptors ranked accordingly to intensity. So you would say 0 for no pain, 1 for mild, 2 for moderate, and 3 for severe pain. And this was measured at the end of the cuff being inflated, the hand grip exercise, and deflation of the cuff. And self-report visual analog scale was completed at 1-minute intervals during the ischemic pain test, resulting in 9 total VAS scores, visual analog scores, rating per participant. 0 centimeters on the visual analog scale represented no pain, and 10 centimeters represented the worst pain imaginable. Strength of the study, included a thorough pretrial face-to-face interviews to establish eligibility in the study. As I mentioned earlier, this established contraindications, prior experience with TENS-like devices, and beliefs regarding effectiveness, safety, and general knowledge of TENS-like devices, which would be difficult to tease out otherwise without a face-to-face interview. Ethical approval was obtained from the Leeds Metropolitan University, where this study took place. Efforts taken to ensure equality between the IFC and TENS application. For instance, the quadrupolar nature of the placement of the units, even though TENS typically occurs in a 2-electrode manner, it was conducted in a 4-electrode quadrupolar manner in this case to make an even playing field. Those are the strengths of the study. Limitations and weaknesses of the study include heavy reliance upon subjective self-report data, both the visual analog scale and the McGill Pain Questionnaire of self-report data. Quadrupolar application of TENS, while it is a strength of this study for leveling the playing field, it is a limitation of the study as well, since TENS in a clinical sense is typically seen in a 2-electrode placement, so that might have skewed results a little bit in favor of TENS. Heavy reliance upon prior TENS research. Throughout this research, the authors continue referencing back to the prior establishment of TENS as an effective method of pain management. In this case, if that research is correct, what follows in a comparison of IFC is correct. Otherwise, this is a limitation. Questionable sham electrotherapy was discussed in the research by the authors themselves that the placement of electrodes alone has been enough to trigger a placebo therapeutic response and to indicate to the participants that they may not be in as much pain as they're actually in, which may skew results. Outcomes and clinical significance. Outcomes include interferential current reduce the intensity of ischemic pain in comparison to sham electrotherapy. Statistically significant differences, however, between IFC and TENS and their ability to reduce ischemic pain were undetectable. So between the two, they couldn't tell which one was more effective in a statistically significant manner. IFC does, however, reduce perceived effective pain as measured by the MPQ when compared to the sham electrotherapy. And while that was going on, the TENS did not demonstrate a reduction of effective pain. Results of the TENS group were in line with the previous TENS research, as I mentioned earlier, in pain management, stating that they were successful in reducing pain according to prior research, or in line with prior research. Clinical significance of these outcomes, the viability and cost effectiveness of IFC as compared to TENS is in question, and the implication for IFC over TENS. Implications for practice. The findings presented here establish the following implications for practice. Interferential current is at least as effective as TENS in reducing experimentally induced ischemic pain. There's a statistically insignificant difference between IFC and TENS as a means of reducing pain. IFC demonstrated a quality of pain reduction not seen by the TENS, i.e. reduction of effective pain. So in this case, if we're comparing the two, if we're comparing IFC and we're comparing TENS, IFC is as effective as TENS. And applications to practice. Support for IFC and TENS as an effective means of pain reduction. So in this case, in the clinic, you would have data to back up your selection of either IFC or TENS as being effective at reducing pain. Potential selection of TENS over IFC in appropriate cases when considering cost to benefit ratios as well as potential for home application. So again, we could refer back to this research to say that I will teach a patient how to use a TENS unit instead of applying IFC to the patient because the TENS unit is more cost effective for the clinic and the patient will be able to use this unit at home. In this case, we can look to the study to say that IFC is no better than TENS, at least statistically significant in this study. Support of IFC over TENS and reduction of effective pain. So I did a little bit more research on this. Authors Horn, Blish, Kuntz, and Lautenbacher in 2012 note that this effective pain dimension of pain is often accompanied by more complex emotional responses to pain, including depression, frustration, and despair. And while further research is needed to establish why exactly IFC was more effective at managing effective pain, this research, however, would be a reliable way to say patients with a more effective type of pain would be a better candidate for IFC. So in that case, patients with chronic pain and patients that are being heavily debilitated by their pain level and causing depression would be a better candidate at this point for IFC until more research is done to confirm that TENS is or is not able to be as effective. And here are my references for the Horn, Blish, Kuntz, and Lautenbacher article from 2012, as well as the original study by Johnson and Tabassum of 2003. Thank you for your time.